Ma'am, you can start.
Yeah. Good evening to everyone. Good evening to my respected seniors present today. And good evening to all the speakers as well as our students. Today we will be moving towards 8th session of our classes. Hope you will be all get benefited. And I'll be very much pleased to introduce our chairperson today. He is Professor Dr. Kushagruti Ghosh. He is our president of Society of Fetal Medicine, as well as he is a very renowned teacher also. He is professor from Ramakrishna Mission Seva Pratishthan from Kolkata, and he is a very renowned fetal medicine specialist in our Kolkata since long. He is the rather first fetal medicine consultant in Kolkata since beginning of 1990 something. So I would very much pleased to welcome sir to introduce our speakers today. Welcome, sir. The chair is yours.
Good evening, Devoshmita. I may be old, but you are the newest. So you've really done a great work in putting all things together and a tremendous work and energy to get this going, this postgraduate session. I hope this actually snowballs into more and more participants and we make it more acceptable so that it is interesting to them. And now today we have two very important topics. I hope people who do scans and people who interpret scans are logged in because it will benefit for both. Because the first topic particularly would be taken by no other than Dr. Kanchan Mukherjee, our dear Kanchan, who is the honorary secretary of SFM Kolkata since its inception for about 4 years now. And he's going to talk on how to generate a report. I think it's very important. This section of the whole ultrasound scanning and assessment is most important because for a busy examiner, for a busy clinician, it's not possible always or to understand the nuances of PV angle and this angle and that angle and write it down somewhere, because sometimes fetal medicine specialists say that I've written everything over there anyway. So if somebody reads the report, we'll come to know. But it's the impression, it's the end of the thing what we write is the most clinically relevant. So I'm sure Kanchan with his vast experience is going to make it clinically more relevant. So Kanchan, the floor is yours. To introduce Kanchan, he is the honorary secretary of SFM. He's done his MBBS, his MRCOG, and then FRCOG. He has done his RCR, RCOG course like all of us, PG diploma in advanced fetal ultrasonography. His special interest is, of course, diagnostic ultrasound and the diagnostic procedures like amnio-CVS and fetal reductions. He has published papers, I know, as far as I know, on thalassemia or Downs, on fetal reductions, and is presented also in various SFM and FOGSI conferences and workshop faculties he has been, and he must have been in some, I've seen him being in international and national webinars as well. So Kanchan, this very important topic is how to write the USA report. The floor is yours.
Can you see my screen?
Yes.
Thank you, Chairperson sir, for the beautiful introduction. And you have already set the stage explaining how important this talk is. Even if you are not doing the ultrasonography, I hope this talk will help you if you are even reading the ultrasonography report. So even before I start talking about how to write a report, I think you should all ensure before writing a report that you are approved by local PNDT authority. Fact that you are all postgraduate trainees either in radiology or in obs and gynae, I presume you are all eligible, but eligibility is one thing and having approval from your local PNDT authority is another thing. Now, those who are working in a medical college setting, I guess you are much more protected in terms of doing the ultrasonography. But if you are having to write a report from that protected environment, then actually you have to make sure that you are PNDT approved and you are doing it properly. Now, those of you who haven't read this report yet, this handbook on PCPNDT must do before going ahead, and preferably keep a copy of this in the room. And you must have seen the gospel statement at the end of almost all obstetric ultrasonography report that I have neither detected nor disclosed the fetal gender. So you should include this. So that's all about the legal part of it, PNDT part of it. Right. Now I have some general comments to make. First thing is, before you start scanning, you read the requisition clearly. I think that is where many of us go wrong. 35 weeks lady appears to your scan room and you presume it's a growth scan. And you don't read the requisition. The clinician might have asked some specific questions for you to answer. And if you don't read the requisition, how would you know? And then write the report as soon as possible after the examination. Don't let them build up for 2-3 days and you write at your own convenience. Obstetric reports are almost always needed on the day or the day after. Now, the reporting sonographer, as the reporting sonographer, you take the responsibility for its accuracy. So if your typist makes a mistake, it's not their fault, it is yours, because it is your name, your professional details, date, signature, everything is there on the report. Okay. Now, your job is not complete unless you have done a proper communication to the appropriate personnel when it is necessary. There are times when you need to pick your phone up and say, see, this is what I have got on the scan, and this is what I have written. The patient is going to call you soon. That's very important. And then you have your limitations. As a fetal medicine specialist with obs and gynae background, I do not know how to report gallstones or how to comment on maternal kidneys. Many times, my colleagues would refer that this is a pregnancy ultrasonography. Can you also please check the gallbladder because the mother is complaining of upper abdomen pain? I'm not qualified to do that. So please do not fall into those, I wouldn't say traps, but temptations. You are trying to help your colleague and the patient, but actually you are not qualified to do that. So know your limitations. And if you want to have further advice, don't feel shy, ask for help. Now there are various formats. Formats differ all over the world, from a checklist to detailed essays to a single sentence even. Like after doing half an hour anomaly scan, one would say, no obvious fetal anomaly detected, end of it. That's not enough. So you need to know what is the best format to suit you. Your aim is to communicate findings to caregiver. So you should actually first find out which format you want to use. And consider your report as a legal document, and it is your main defense in case a complaint arises. Now, our society, Society of Fetal Medicine, in its anatomy scan guideline says you may include a statement like followed SFM protocol 2013, that is when the guideline came out, or the International Society of Ultrasonography and Obs and Gynae guidelines in 2010. If you want to include a statement like that, that's fair enough. And whenever necessary, use a short description of the findings. And my particular suggestion would be have a checklist handy. For each and every patient, if you have a checklist held with your attendant or the typist, they can guide you that, sir, you have, madam, you have missed so and so things. Can you please check? And those of you who haven't read this international bestseller book by Atul Gawande, the Checklist Manifesto, I suggest you read that and you will realize checklists do help in life. Right. Report style. They should be concise, clear, and easily understood. Standard reports which are understood and accepted by staff within a hospital may need to be modified for outside referral. Just 5 minutes back, Dr. Ghosh was suggesting that if you say BV, BT angle, It may be familiar to you or to your unit, but to an outsider, it may not be. Like if I write SLIUP, how can I presume that that is meant by single live intrauterine pregnancy? Then avoid potentially ambiguous phraseology like ventriculomegaly. I mean, one patient had mild ventriculomegaly and she was then referred to a cardiologist, adult cardiologist, while actual problem was fetal cerebral ventriculomegaly. CDH equals to congenital diaphragmatic hernia, the orthopedic surgeons will take it as a congenital dislocation of hip. So avoid these ambiguities. And then you group abnormal and related findings together and then create a new paragraph. And then maybe you group another set of findings which are related to each other. Okay. Avoid irrelevant information. And you will know that differs case by case. And technical jargons. Again, if you say CPR to an obstetrician who hasn't been updated in the last 5 years, may say, what is CPR? That's cardiopulmonary resuscitation. But until and unless you say it is cerebroplacental ratio, it may not be clear. Similarly, CVR, that's CPAM volume ratio. You cannot expect your obstetricians to know that. When you are dealing with clinical content, you address the clinical questions pertaining to referral reason and be conclusive wherever possible. And if it is not possible to draw a conclusion, you offer possible differentials. Okay, and put yourself in the shoes of a clinician so that your reports guide the referring clinician in further management. Now, if you are writing a report on the patient's notes from an internal referral, the patient may be admitted in the hospital, then you should mention that it is a provisional report and printed or verified report would follow later. Write the notes, write your reports in an appropriate part of the notes, date, sign with full name and status. Writing illegibly, including your name, does not help. You will be found out. So there is no point hiding your identity. Right. Images. They are an integral part of reports. Now the question is, how many images do you include with a report, with a typewritten report or a handwritten report? Well, the answer is, I don't know. There are many things to balance here. Cost being the main issue. Now, whichever you feel appropriate and whatever your employer allows, follow that. Now, the next question is, do you give only thermal printouts, or do you give a radiological film, or even soft copies? Now, soft copies in a pen drive or a CD may last longer, but in our settings, the clinicians may not have access, proper technology to see those. So again, I don't know the right answer for that. Whatever suits your settings, you do it. If there are findings, I suggest you save video loops on your machine so that you can refer to those at a later date. Now comes the issue of archiving. You are saving too many videos, your machine will hang one day. So save video loops, save as many images as possible in your machine so you can defend yourself at a later date. But then you need to take backups time to time. So in case the machine is replaced one day, then you will not lose your data. I will now give you some examples of examination-specific reporting, like first trimester dating. You need to mention whether it was a transvaginal or transabdominal, and that you have taken consent and there was a chaperone. And then you write a statement like single intrauterine live embryo of CRL of 18 millimeter, which corresponds to 8 weeks, 3 days. Whether you have seen yolk sac, subchorionic hemorrhage, and how was the adnexa, etc., should be mentioned as well. and you need to calculate the EDD. So the clinician can see in the first trimester dating whether it differs by more than 5 days with the LMP derived EDD. So either you or the clinician can finalize the EDD with that scan report. And then you should guide them also about further management like combined first trimester screening. You should give them an idea when that should be done. If it is a pregnancy of unknown location, then again, you say whether it's a transvaginal scan or transabdominal, you describe the uterus, whether it's anteverted or retroverted with endometrial thickness. Have you seen the gestation sac? Where was it? Ovaries? Have you seen, are they looking normal? And then even if you cannot see the sac or evidence of pregnancy, if you mention corpus luteum on the left side, the clinician may have some idea that ectopic may be on the left side. Okay, these are all little clues that you are supplying. And then if there are adnexal masses that you should mention, and was there any tenderness during TVS? Was there free fluid? And then finally you draw up a conclusion with all your evidence, with all your findings. Suggest a follow-up plan, like when that patient should be scanned again. And if you want a beta HCG report done, you can also discuss with the clinician. So think laterally, I would say. Twin pregnancy. Any twin pregnancy report is not complete unless you have mentioned chorionicity. If it is in the first trimester, you can also describe the findings, whether it looks like a T or lambda in terms of the dividing membranes. Then you should try and map the twins. Which one are you calling twin 1? Is it lower maternal left or twin 2 being upper right, etc.? So try and map the twins, level them as much as possible. Crown rump lengths, of course, must be mentioned for 2 different fetuses so that the EDD can be calculated based on the larger CRL. And again, you guide them for further management like FTS, first trimester screening. Now comes a very common reporting issue with NT scan. NT scan, again, mention whether it's transabdominal or transvaginal or both. Accurate date of birth for mother or for egg donors in case of IVF must be mentioned. Then crown rump, you do all your findings. Okay, CRL, NT, nasal bone, ductus venosus, tricuspid regurgitation, you have done everything. But how do you calculate the risk? For that, you have to be approved by Fetal Medicine Foundation. If you are not approved and you are doing an ultrasonography, then at least you can have an idea about the centiles. Suppose the CRL is 62 and NT is 2. You can see this is 77th percentile. Now, if you want to calculate the risk level, then how do you do that? Well, I'll show you in a minute. For risk calculation, one has to be certified by Fetal Medicine Foundation, and there they use the Astraya software. This video is available on the YouTube. So when this evening YouTube stopped, I panicked a little. This is a 2 minutes video. Okay. First thing is register the patient with name, date of birth, and all that. Then you write the indication. It's all drop down, and then you proceed with the operator's name, add all the findings. See, there's the operator name, and then you say whether it's transabdominal, transvaginal, racial origin. So all the patient data is fed. Then you give further details, whether there was any previous trisomy, parity, and
The slides are not moving, Kanchan.
it's not moving.
No, the same slide is going on. Is the slide you're talking is on NT scan?
NT scan YouTube Astraya software.
We can't see Astraya software on your slide. We can only see NT scan. After that, TAS or TDS, accurate DOB of mother or egg donor's egg. We are in that slide.
You are on this slide.
On this slide, where it is written Fetal Medicine Foundation underlined.
Yeah.
And then the YouTube link is there.
Can you now see the? Can you now see another screen?
Yeah. No, sir.
No.
We can see your pointer.
You can you see me typing 62?
No.
No. Sorry, that didn't work in that case. Okay. The
So
link.
Go back. I think you go back one slide. No, yes. Now start from now again. Type, then go to the front side, then go to the next one.
Yeah, that is working. But whenever I am clicking on the internet, that is not showing up.
Yeah. Okay. Now it's showing.
Fine. Okay. So I have to forget about.
This is anomaly scan.
This is anomaly scan. Again, I have a hyperlink, but that is not functioning. I thought that will also be seen by all of you. Anyway, if it does not work, fair enough, no problems. So that is how you report the NT scan. You have to have the software. It does not cost you. It's free of charge, but you have to be approved by Fetal Medicine Foundation. And for your approval, you need to do an online course followed by 3 perfect images. And in order to obtain 3 perfect images, one may need to scan 50, one may need to scan 100, depending on the person. So, and once you have obtained your license, year on year, you have to renew your license to use the software. Okay, next common examination is anomaly scan. For anomaly scan, again, there are so many things to see. So there had to be a structured reporting format. And one good reporting format is the one provided by International Society. And you see there is a checklist and you go through them and you conclude at the end, there's normal, complete examination, normal, but incomplete examination, like that. Okay. And you should also read the SFM guideline on fetal anomaly scan. There I haven't found a pro forma, but I believe that will come up later. I have already said that think laterally. If you find one abnormality, don't just stop at that. Keep looking for more. And this was a case of twin pregnancy, IVF twins, and one had absent nasal bone, the other one had present nasal bone. The one with the absent nasal bone also had high echogenic bowel. So when it did amniocentesis, this one was Downs, this one was normal. And then we did a selective feticide there. So basically, if you stopped at just absent nasal bone and nothing else, didn't guide the clinician about amniocentesis, then this would have been missed because it was already 17 weeks by the time she had these findings detected. Okay, I know there is another separate talk on growth scan, growth charts, but I will just mention how we generate a report on growth scan. First thing is mention the dating method, whether you are deriving the dates from LMP and which corresponds with the first trimester dating scan, or you are deriving the EDD by CRL at the first trimester. So that should be mentioned. There is no point giving multiple EDDs on multiple examinations. 24 weeks, you give one EDD, again 32 weeks, you give another. Absolutely no point. You cannot shift the goalpost like that. Well, you have to take your BPD, HC, AC, FL, all biometry. But then if you keep on giving different gestations for each biometric parameters, then it does not help. Instead, you should use centiles, and these centiles are available on the machine. So forget about using weeks and days. Instead, you should use centiles figures. Similarly, with amniotic fluid volume, if you can give a chart, it helps. Doppler findings, again, should be plotted on the chart. Now, if on the report you say good fetal movements seen, well, the clinician can ask the mother whether she's happy with the movements. It helps even more if you say fetal breathing movements could be seen as well, because the clinician will then know that brainstem is working fine. Okay, and then do you suggest any follow-up plans? Now, this is an example of machine-generated charts. Current day machines are very clever. Suppose this is a lady who is being scanned at 35 weeks, and this is the abdominal circumference. It plots there. But does it tell you enough? It will tell you even more if you plotted all her previous examinations. You didn't have to plot. Basically, if the patient was scanned on the same machine, then the machine is plotting them. You just have to change the plotting system from current to trend. See, on the previous slide, I was plotting on the current. Now it is trend. And then that tells you how this AC is behaving. Another example, this is current plotting at 36 weeks. You would say it's on the 3rd percentile, but the moment you see the previous report, you will pay even more attention because it has dropped. Okay, so without a chart, your job is incomplete. Now, suppose you are you are the clinician, your sonographer has not been kind enough to give you a chart and you are at a loss. It's not difficult to download a fetal growth chart from the internet or have a few copies of these graphs on your table and you can plot them. Suppose this is a fetus who is small for dates and this one is fetal growth restriction. Until and unless you plot them on a chart, you won't be able to differentiate between these two conditions. Another example, placental localization. Many times you get a report low-lying with previous cesarean section, and the report does not say whether there was any evidence of adherence. But it has to be mentioned. It has to be mentioned, otherwise there will be disaster if it was a missed placenta accreta. Whether there is any evidence of vasa previa. Now, a couple of examples on condition-specific reporting, where the knowledge of specific condition is important. If you think that you need to read up, you can read up right after the scan and then write the report. But try your best to give them maximum information. Suppose you are dealing with a case of spina bifida, where you describe the findings. Do you see cranial changes like lemon signs, lemon skull, banana cerebellum, or do you see ventriculomegaly? And then you mention the level of the lesion, whether there was meningocele or other contents. Was there any cord tethering? Because that indicates prognosis. And then at the end, and hydrocephalus. So try and guide them with the prognosis as well. Even if you do not want to write the prognosis level, the person reading, suppose this fetus, this condition is detected at a later date, at 28 weeks, and then they have gone to a neurologist, pediatric neurologist. They would like this information to prognosticate this baby. Another very common condition, renal pelvis dilatation. If you just say renal pelvis looked relatively full, that's not enough. You have to speak the universal language, which is now available through urinary tract dilatation classification. Now, again, I put a hyperlink there, but that's not working. If you read this paper, you will realize that there is a structured way of reporting urinary tract dilatations. You have to describe the findings, like how did the calyces look, how was the parenchyma, are the ureters dilated, how was the bladder wall thick, like those. Mention the AP diameter. If you are giving some measurements, the minimum, basic minimum is the AP diameter of renal pelvis. Without that, if you just say renal pelvis looked full, does not mean much. Is there any, once you have found renal pelvis dilatation, then you have to look for other ultrasound markers for abnormal karyotypes. And then you may have to recalculate the risk level for Down syndrome by genetic sonogram if the patient is in the second trimester. And on the next slide, I will show you how is that done. You have to again suggest a follow-up plan and offer a pediatric nephrology consultation. So your job does not end only by writing renal pelvis dilatation. Now, this is a practice-changing paper published in 2013, where they systematically put all the soft markers, so-called soft markers, which is not a favored terminology these days. It's ultrasound markers, they call them, into an Excel sheet. Screen sharing is stopped. Oops, sorry. Can you see my screen now?
Yes, yes. Okay.
I'm just coming out of that screen. I want to show you the Excel sheet here. Okay, can you see the Excel sheet now?
No.
Right. So this is again a free download Excel
No,
sheet.
we can't see the
we
Excel
can't
sheet.
see.
You can't see the Excel sheet.
No.
Sorry, coming out of the Excel sheet again.
You can open the Excel sheet and do the screen sharing. And then
Again,
we'll
stop and then share again. Yeah.
Okay.
share it again.
Because unless I show them the Excel sheet now.
Yeah. Now open the Excel sheet.
Excel sheet is open on my screen.
Now
No,
do
share
screen
screen
share.
again.
Now screen share.
Now it says stop sharing. The option is to me now stop sharing. That's not what I want.
Sir, you already stopped the sharing. Please share again.
Share.
Yeah.
No.
Now you're seeing
Open the
my
Excel now.
slide. Now, if I click on the Excel now,
No, is the Excel thing open?
yeah.
Yeah, but you'll have to minimize your PowerPoint.
Other PPT, yeah.
You'll have to minimize your PowerPoint and open only the Excel sheet on your desktop.
Yeah, trying that.
The Excel sheet is not open on the desktop.
I'm now opening again.
Yeah.
Sorry, I think I'll continue. Now, basically, that Excel sheet gives you the weightage for each and every ultrasound markers. And if you use the drop-down menu there and say something is present, like absent nasal bone, you say yes. And then the likelihood ratio is about 23. And then you say absent echogenic intracardiac focus, then it pulls down the risk level. So there are 8 different soft markers, and that actually finally gives a combined risk level for Down syndrome. And if you keep that handy in your scan room, then it will give you a better reporting options. So at the end, I will say there are web resources, and you can use Fetal Medicine Foundation, you can use Barcelona Fetal Medicine or perinatology.com, and our very own Society of Fetal Medicine, which now has a wealth of data, and it is coming up every day. More and more is being added there. So to take home, I would say, ensure that you are PNDT approved before you write a report. There is no substitute to necessary knowledge base. And then put yourself in the shoes of a clinician, and then you can then write a better report, and use web resources as much as possible. Thank you. I'm sorry I couldn't show you many things that I wanted to. Never realized that it won't be shared.
Well done, Kanchan. You have spoken very well. It's very relevant and very practical. May I ask you a very tricky question? Now, a lot of reports at the bottom has a disclaimer, or some people put a disclaimer at the end of it in a separate page. The scan is not 100% accurate, and so on and so forth. And so what is your feel about a disclaimer in a report, a routine disclaimer in a report?
It gives the operator a feel-good factor, certainly. And if it is evidence-based, there will be some difference. That I never claim that it will be 100% accurate for cardiac anomalies or conditions like agenesis of corpus callosum. So if you say that it is not accurate 100%, patient also goes home with some impression that this is not a perfect report. This is not, there may be limitations. That message should go through.
Well, let me ask Dr. Khurana, what's your opinion on it? It's a very tricky question. Are you there, Ashok?
You see, the problem is that there's this expectation that there's a guarantee in everything that happens in biology. And that is the expectation of the patient, particularly if they paid a little more compared to your average street scan. The point is that, unfortunately, in the consumer forums today, we have people who have a judicial background, but we also have a lot of people who have a non-judicial background. For them, a remark like this is very necessary, that we cannot pick up 100% of anomalies because of position, blah, 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 etc., or that it is a biological process and has statistical limitations. So I believe that because of the prevailing legal environment that we are living in, a disclaimer like this is justified. Although if you were to have a true judge sitting in judgment, say at the High Court level, then they would say no, then they would look at it from the point of view of negligence, if at all. But then they are qualified to look at it from the negligence point of view. In the consumer forum, this is not always true. So from that point of view, and also from the point of view of frivolous litigation, this is a useful remark.
Yeah. I mean, I tend to include one line in the report at the end, just because of this, actually, because who is sitting there, we don't know.
I do exactly the same thing, yes.
My disclaimer is at least half a page. Sometimes bigger than the actual report.
Yeah, I'm doing a hide and seek thing. You can't catch me type.
Yeah.
Okay. The other thing is, because of so much of fetal medicine talking everywhere in the webinar, there are many very budding fetal medicine specialists I have seen. There's, for example, they're concentrating on they're concentrating on FTS, and they forget to see the myoma or an ovarian cyst. Recently, what had happened was a FTS was done, and 4 days later, the patient was admitted with a twisted ovarian cyst and had to have an operation done. And then there was a question why this was missed during scan. So these are things which are very important to be emphasized in the report, which means the reporting system. Like, we should not just immediately go into the fetus. We should always see laterally on both sides and the myometrium. So that is something that I wanted to point out. And the other thing is about one thing we have noticed is reporting on twin 1, twin 2, or twin A, twin B, or F1, F2. This is a real messy thing. And this is something I don't know how to, we know the guidelines. Yes, you follow the amniotic membrane at its attachment at the lower pole, and where the internal loss is included, that you can consider as twin 1 and the other one is twin 2. But often this is missed. So
You mean to say regarding the disclaimer?
whatever. So that we can all learn from you.
Can I put a different twist to Dr. Pravin's question?
Pardon me?
I mean, can I add a different twist to your
Please,
question?
please. Go ahead.
Suppose someone has been requested with a growth scan, and the operator does a growth scan very well, but missed cardiac anomaly at 35 weeks.
Mhm.
Can they defend it?
Can they?
Defend, justify, saying,
no,
I have
no,
been
you-
asked
no,
to
you
do a
can't,
growth
you can't.
scan, and I did not want to see the heart.
No, you can't. You can't. You can't defend yourself. So that actually answers the question also, because there are many twists in this, in the sense there are some people like a consumer forum or the judiciary. There are some judges who are more sensible to understand that there are some limitations as far as evaluating the fetus is concerned. But there are some people who are absolutely dogmatic and adamant, and they don't really understand. For them, more than your disclaimer, it is your references or the evidence that you are going to show when you are pulled up is what is going to help you, not the disclaimer. Disclaimer can be just thrown into the dustbin, because there is no value for it. Because if you say that I did not see, that obviously means that you are supposed to look for it. If you have not looked for it, it is your mistake. So, and if you say that I could not do a fetal echo, then you are not supposed to look into it. So these are very tricky and controversial situations. I think it is difficult to really defend ourselves just because a disclaimer. But as you have said, it's a feel-good factor that, yeah, I have already mentioned that. So I personally feel that way.
Now, a statement which I find completely useless is, it says it's a clinical report not for legal purposes.
Right.
I don't think
The other thing which might help is if you find something out of the ordinary, just not to put it in the report only, but to give a call to the referring doctor and tell them that this is something which you have found and this is what I think.
most
This might
important
be a
thing which I find is communicating with the patient. I think you need to talk to the patient. You need to explain the patient. You need to tell them the limitations. Suppose if I can't really do a satisfying fetal echo evaluation, I would like to sit with the patient, tell them that these are the limitations which prevented me from doing a satisfying fetal echo because of such and such a limitation. So that way you are going to educate the patient. At the same time, you can always call the clinician who is referring clinician also and tell them that this is the limitation. And you can always ask the patient to come back again. There is nothing wrong in asking them to come back again, because after all, you need to be satisfied in what you have done, and then only you can give a report about it. Or if suppose the patient says that he cannot, then mention it that because of these limitations, we were not able to evaluate the fetal heart properly. That's it. I think that will be better.
Can I add a point as well?
Yeah, please.
Of course.
Thank you. Yeah, the other bit is if you are writing the disclaimer, it's important to explain to the patient that as well, because a lot of them sort of read that and go into so much of anxiety and confusion as to what you have written exactly, and then you get phone calls or they come back with the report. So whatever is written in the report, you must explain or tell the couple about it.
That's why actually